Good afternoon. Good afternoon. This is Dr. Scantlebury, and I am the medical consultant for Dialysis Patient Citizens Educational Center. And today is September 4th, 2024, and it's a beautiful day outside here in Delaware. And I'm happy to be here. Thank you all for joining. It's been a month since July 3rd, and I welcome all of you. And thank you. Tell your friends, tell them to come on so you can ask me your questions. Thank you for joining. Again, I'm Dr. Scantlebury, and I am the consultant here at Dialysis Patient Citizens Educational Center. Well, today is September 4th, and September 4th is actually Polycystic Kidney Disease Awareness Day. So we're going to talk a little bit about polycystic kidney disease, and if any of you have any questions, be sure to put them into chat. It's really about bringing awareness about kidney disease caused by polycystic kidneys. Polycystic kidneys is generally an inherited disease that you can manifest from birth, and it's an autosomal disease that you can get the gene either from one parent or another. So it's really inherited, and a small percentage of patients will actually have polycystic kidney disease as a aberrant mutation without having any parents with polycystic kidney disease. So I have seen that as well. So what happens is that as the kidney develops, when you develop polycystic kidney disease, it can manifest in these cysts within the kidney, which slowly over time can displace the substance of the kidney, and the patients will present with high blood pressure. Sometimes the cysts may rupture, and oftentimes patients may even have blood in the urine, pain in their kidneys, in the flank of their kidneys, where the kidneys lie, because as the cysts grow, so do the size of the kidney. So many patients will end up with very large kidneys. Some patients also have, besides polycystic kidney disease, will have polycystic liver disease, and it can also affect the pancreas. So for those of you joining today, September 4th, and we're talking a little bit about polycystic kidney disease, which is celebrated today, September 4th, to bring awareness and allow patients to know more about this disease, and also to, there's polycystic kidney disease organizations that you can volunteer with, donate your time and your money to help go to research, because there's really no cure for polycystic kidney disease. Some patients have a slow progression, others will go, and so those who are diagnosed early in life may end up having their kidneys replaced because they have developed end-stage kidney disease early. But generally, it takes a few years to get there. There are some newborns who are was diagnosed in utero and would end up on transplant or dialysis earlier. But for most people, you will go on to adulthood, and you can live into your 50s or 60s, depending on when your kidney disease develops. I've seen patients who have massive kidneys that fill the abdomen, and it makes it difficult to do peritoneal dialysis, because often the kidneys can be the size of footballs, taking up most of their abdomen, going way into the pelvis, not leaving enough room for peritoneal dialysis. There are some patients who will have polycystic kidneys that will remain towards the back without consuming a lot of the abdomen, and they may be a candidate for PD, but generally it becomes what's the size of the kidneys. In some patients, the kidneys may be enlarged or significantly, but in many patients, they also have a good portion of their liver with multiple cysts, and so for many patients, the liver can also be taking up about half of the abdomen. So this makes it difficult for some patients with polycystic kidney disease to have peritoneal dialysis, just not enough room in the abdomen. There are some patients that I've seen who appear almost as big as if they're 6 to 8 months pregnant because their kidneys have enlarged dramatically. Even for many of those patients, when they come to transplant, we maybe require removal of their kidneys or kidney on one side, but you don't want to leave them in balance with one big kidney, because the kidneys that can extend so far into the pelvis that there's not enough room to place a transplanted kidney. So it varies from patient to patient. The risk is certainly most of them, you will have high blood pressure, and you may have blood in your urine. Some of the cysts can rupture and you can have a significant bleed. They can also get infected. So you may present with infection in the cyst. So it's important to, if you have a tremendous amount of pain, to get it checked so that you're understanding what's going on with your kidneys. And it's just a displacement of these cysts. If you can imagine a bunch of grapes, and the cysts would all vary in size. They can be as large as an orange or a grapefruit and as small as blueberries. And so they're multiple size. But what happens is there's very little kidney tissue left between these cysts. And so there's not enough kidney tissue to function. Is there a cure? No, there's no cure as yet for polycystic kidney disease. But you want to be able to delay the onset of kidney failure. So you want to be followed by a nephrologist. There are some treatments out there that work for some patients. I've followed a patient who was in a study, and from the time she was about 20, and she got to almost 30 years in this study before she ended up needing to have a transplant. I've seen patients who the kidneys were not necessarily as bad as the liver, and I've actually seen some patients who ended up with a combined liver and kidney transplant because the liver was so humongous that when it was removed, we couldn't even, to have one person hold it was tremendous. It in itself weighed about 20 pounds. So it depends on what, and for that person, they actually underwent the liver transplant because of chronic fatigue. They could not walk around or do anything because it was almost like being 9 months pregnant all the time. So those are, certainly there are promising results. As someone put a question in terms of, because it is familial and inherited, you can have families all receiving. If your parents have the gene, you can run the risk of having both genes, 25% chance with each child to be able to, who will then have polycystic kidney disease. And the progression may vary from one to the other. So it's often important if parents have it, or one child have it, to test the other so that you know what the risks are going down the line, and they can get into a study and be managed by the nephrologist in terms of looking for signs and symptoms in order to decide when to intervene. So thank you very much for that question. And so as for those who just came on, we were just talking about polycystic kidney disease, as today is September 4th. And usually this is Polycystic Kidney Disease Awareness Day, which falls appropriately on today. So definitely had to bring awareness to this disease process of this. Any of you out there who have polycystic kidney disease, dialysis, or transplant and doing well, or just sort of, put a comment in the chat as let us know how you're doing, and also to be able to ask you some questions. So thank you so much. There was another question in the chat. What is your take on COVID immunization for renal patients? Certainly, we want to avoid the illness. We have the new strain of COVID is actually causing more hospitalizations. And so the number of infections are on the rise. There is no requirement for hospitals to report deaths. So there's no real data collecting on if anyone is dying from it, but we do know that hospitalizations, at least here in Delaware, we're tracking hospitalizations as well as those in the ICU, and there are more and more admissions. I know around me, I actually got COVID about a few weeks ago, and so now I'm protected at least for 2 months or so. But this month is in this week or maybe next week. I know the new booster has been approved by the FDA and is available. It should be available to your pharmacies, actually, if this week or next week. And so it's important for renal patients because you are immunocompromised. You are at risk for higher risk for developing complications from COVID. And so I feel that it is important to get get the new booster because you want to definitely decrease your risk of getting ill, decrease your risk of ending up being hospitalized and getting dehydrated or anything that may compromise your kidney function. So that is my advice, to definitely think about the advantages of getting the new COVID booster that is available. And the fact that it is still around means it probably will still be around and is still causing hospitalizations. But the same thing is also true for the flu. We often have thousands of people being hospitalized for the flu. We don't hear about it but we do get vaccinated. So this is going to become a routine once a year or twice a year. We know right now the vaccines wane at about 4 to 5 months. So the CDC is recommending that you get vaccinated if you've gotten your last vaccine sometime, certainly earlier this year or the end of last year. Yet it will be important to get this new vaccine. And the CDC did put out that it's okay to get your flu vaccine and your COVID vaccine at the same time, in a different arm if possible. But it's okay to allow your body to be able to build immunity to two things at the same time. Certainly, you want to make sure the flu, I'm sure many of you have had before, is not very painful. I've actually had both at the same time and actually had RSV also with my COVID vaccine as well. So definitely I advise for those of you who are on dialysis as well as kidney transplant to go ahead and get your vaccine, get your flu vaccine, as we are entering also into the flu season. I know there are those of you who are anti-vax, and you're entitled to your rights or your opinion as well as your beliefs. But certainly the goal is to make sure to keep you out of the hospital. You want to make sure you're vaccinated, certainly with COVID, with flu. The RSV vaccine is now being reserved for those over 65 and instead of the lower age. And so definitely get your vaccines as well as your pneumonia if you fall into that age group as well. Thank you so much. Again, my name is Dr. Scanterbury, and I'm the medical consultant for DPC Educational Center. And today we were here talking about polycystic kidney disease, which is today's Polycystic Kidney Disease Awareness Day. And we're also talking about vaccination as we enter the fall season. We know this is the flu season as well as the new COVID vaccine boosters that are available. So we want to welcome, as Yolanda said, welcome all the patients and members, and we want you to tell your friends, tell those who may be on dialysis as well and who are sitting next to you or who have been transplanted, to go on to the website and sign up, get informed. There are many different educational sections on the website, and so much you can learn. There is recipes for you to try out and you can alter them to your liking. And there's a whole lot being kidney disease treatments advocacy, and there's many of you on here who are ambassadors, so that you can become a patient ambassador. So definitely we want to make sure that you get all the information that's possible So thank you all for joining. If any of you have any questions, please continue to put them in the chat. We were talking about kidney disease and polycystic kidney disease and vaccination. As we enter, we're coming out of summer. Hope all of you have had a good summer, and even though it's not quite ended, but so the question is, what can be any other questions? I see there's another one. Do you recommend self-cannulation for dialysis patients? Many patients, when I speak to them in terms of even beginning to encourage home dialysis, there's always a reluctance because there's that fear of wanting to put the cannulas for self-cannulization. But you're taught how to do it. And I'm sure that those who are teaching you will not advance you to it until you have a certain level of comfort in doing it. I know currently, I think the rules are you don't have to have anyone with you, but it's always a good idea if you're home alone to see if there's someone who can be with you as you are getting on and off the machine to make sure that there's not any issues, and also someone to help you. But it's many patients do it. And if once you get the hang of it, it's certainly something being able to I'm assuming, Nancy, this is a question in terms of home dialysis, in that you are now having the advantage of being dialyzed at home. So if that's your option, remember, they don't leave you on your own. They teach you how to do this. If you're willing and capable of doing it, although I get pushback from many of my patients when I talk about it. So it's certainly for in-center, I'm not sure if that's, I have no great opinion on in-center cannulization. I think that if you're there and you're able to do it and the nurse is watching you and you're willing to do it, that's certainly, but it's still their responsibility when they're there. That's my feeling from that standpoint. So what is your opinion? Put it in the chat so I can see what are your thoughts about self-cannulation for dialysis patients. The idea, the current status of the flu, RSV, and COVID, yes, certainly the flu and COVID is recommended. You can have both of those together. I've actually had patients have all three together because they didn't really want to come back to get another shot. So certainly, yes, you can have your vaccines, and you usually say, take some Tylenol. If you're achy, you might have a little trouble sleeping that night, but generally most people are okay. Generally we said just, take some anti-inflammatories and you usually do okay after that. So any other questions? Thank you so much. And definitely for those who need to have the pneumonia vaccine, please go ahead and do that because that's also important. And shingles, for those who qualify for shingles vaccine, we definitely want you to do that because getting shingles is very painful. It can leave you with a long-term neuropathy which means you have a lot of pain long after it has dissipated, and even as your vesicles have dried up because the shingles, so the herpes virus gets into your nerve, and therefore it lives there and can continue to give you nerve pain. So it's definitely something that I recommend. In terms of for transplant patients, generally we tell them that neither you want to talk to your nephrologist. We don't recommend vaccinations right after transplant because your immune system is generally immunosuppressed because of all the medications. And generally for 3 months, they tell you to avoid vaccines because you may take the vaccine, but because of the high level of immunosuppression to prevent rejection, it's also going to prevent your body from making antibodies to the vaccine. So check with your pharmacist and your nephrologist to see whether it's you're in that realm. If you're being treated for rejection, you may not want to have the vaccine because your body may not respond to it well enough for that. But we do the flu and RSV, the vaccines that are kill vaccines, and not live vaccines, you can have. Recovery from myocardial infarction on dialysis, finding it hard to get my strength, starting cardio rehab today. Very good. And, generally remember as you on dialysis and your heart has suffered an insult. So the goal is to be able to slowly gain your strength back. Many people will need cardio rehab for a few weeks to even, it's now 6 weeks, depending on how you recover and gain your strength back. So hang in there and hopefully you'll get back to where you started. Lots of talk about sepsis. How can it be avoided? When you think about sepsis, it's really an infection at your site of entry of bacteria into your body. So where is that site? For patients on hemodialysis, it's going to be at the cannulation site, making sure that your skin is clean, making sure that you don't touch the cannula before it's inserted. Don't put it down on the table anywhere, even if you say it's on a ABD pad or something. Don't, as long as once you take it out the packet, make sure that your arm is ready and prepared to insert it without touching anything. You want to make sure your hands are clean. You want to make sure that you're not talking. You should wear a mask to prevent your saliva or different things, any spitballs that may come out or to get on the cannula. So you want to avoid infection. If you are a PD, it's really about your connection, because once your insertion site, if it's well healed, it should not be a source of infection, because once the scar tissue comes together, then there should not be any skin flora going into your abdomen at the insertion site, because the catheter itself is tunneled along for a couple of inches before it enters the abdomen. But you can get an infection site. Most of the time, your contamination comes from the connection of when you put together. So here again, you want to make sure there's no body contact or skin flora coming anywhere near where you make your connection. So keeping your hands clean, wearing some gloves, covering your face to make sure that no mouth flora or just articles that come out your mouth while you're trying to do this. You may be shouting, telling someone to be quiet or something like that, and you can contaminate the connection. So it's really about keeping that site clean. Once that site gets infected, now you've got bacteria enter into your bloodstream, because this catheter and this connection is directly into your body or your peritoneum. And so then you get peritonitis. For your hemodialysis, you get sepsis, you get bacteremia, you get a fever and chills. Sepsis is when it begins to go from one area to another. So not only is it then in your bloodstream, you now have pneumonia, you now have urine infection, and so the bacteria has now traveled to different parts of your body because you are immunocompromised and you do not have enough white blood cells and immune system to block that infection, and that can be devastating. So you want to avoid any infection by being careful about where you make those connections, keeping your space clean. If you have pets, you want to make sure they're not coming up in the area where you're making your connections at home. And it's really about keeping that site clean and doing your best to avoid contamination. And remember, most of that contamination is from your skin, your hands, or anything that contaminates the catheter from there. So thank you for that question. When dialyzing at home, how long is a nurse able to stay with you? I am not qualified to answer that question, because the nurse, depending on your needs, what your insurance will pay for, and in terms of having a nurse with you. So maybe someone else can answer that question. If it's home dialysis, generally they allow you to go. There are stages of which they go in terms of letting you be comfortable, watching you cannulate to make sure you're doing okay, That's the hardest part. Taking the catheters out and holding is you want to be able to manage doing that. So for each person, I would assume it's different, but I don't really have that information. So sorry about that. Again, this is Dr. Scanterbury, and I am the medical consultant for Dialysis Patient Education Center, and we are here as the Doctor Day, and you can ask me your questions. We got about 5 minutes left. For those of you, thank you for joining. And let me see, transplant after heart attack, a go or a no-go? Generally, for most people, after you've had a heart attack, they want to make sure that, one, depending on how you're treated, if you had recovered and need stents placed, you're going to be on an anticoagulant. And so for many cardiologists, they will say wait 6 months to make sure your heart's recovered, depending on how sick you were and what your complications were. And so that's a minimum. For some, depending on the extent of your heart attack, you may require another echo or cardiac cath to make sure that your heart has recovered. Depends on the extent of the muscles that are compromised from the heart attack, because when you think about a heart attack, it means that some part of your heart muscle is not getting enough blood. And so therefore, that part of the heart is no longer going to be able to work as well as it would before. So you'll have a compromised pumping mechanism. So they will wait until you regain better function of your heart. As one other person, you may have to go to cardiac rehab. You may need to have retesting, but generally most transplant centers will put you on hold until your cardiologist gives you clearance to be back on the list, but not until you are cleared and functional and making sure that your heart can handle the transplant, anesthesia and all that, even after you've recovered. So certainly if you've had 100% blockage and one stent, if your heart wasn't compromised and there wasn't any major damage to your heart muscle, it's just a matter of, if you have a stent, you will need to be on anticoagulant. And most transplant centers will wait until it's safe to remove you off that based on what the cardiologist says. Some cardiologists will say 3 months is okay, and others would say 6 months is okay. Others would say perhaps a year. So depend on where that blood vessel was clogged and your recovery. So thank you very much for that question. Many of you, thank you for joining. We're coming down to the last 2 minutes. Certainly you want to, as you get worked up, as one of the transplant evaluation processes is really to make sure your heart's in good shape. And that's why we put you through echocardiogram, stress tests. And with those, we want to make sure that your heart vessels are doing well. For some patients, that stress test is positive, indicating that there is a problem in your heart muscles getting enough blood. And so you go on to needing a cardiac cath. And that cardiac cath is there for us to be able to know whether or not your heart's in good condition, whether or not some patients who would have had a silent heart attack even before without even knowing it. And now we've seen an area of the heart that's scarred. And so it's important to prevent another heart attack from occurring. And that's the importance of doing that cardiac cath, to make sure that, yes, we would like to give you a transplant, but we also want to make sure you're going to survive and do well after that transplant without having you succumb to the complications of heart disease. So that is why we put you through the rigors of knowing what your heart's capable of, so that you can withstand the anesthesia, you can withstand the immunosuppression, as well as any treatment for rejection that may be hard on your system. So I know the workup seems like a lot, and we also require that annually you get cleared by your cardiologist. So annually you also get either an echo or stress test to make sure you're doing well. So thank you so much for your questions, those of you that stayed on and asked all the wonderful questions. Again, this is Dr. Scanterbury. I am the medical consultant. I hope I've answered your questions. And stay well, be safe, and God bless. Take care.